Hey everyone, welcome to the first episode of 2025 of Transforming 45. And this episode is a banger. I recorded this episode in November, and the wisdom and knowledge and skill of Dr. Sarah Wilson has been rolling around in my brain ever since. This episode is an essential listen for any woman in your life, really. You don't have to be perimenopausal or menopausal to learn about what's happening in your body. And Dr. Sarah Wilson brings such a depth of knowledge of what happens in women's bodies across the reproductive cycle, and particularly at this stage. So I really hope you enjoy this episode. Have a pen and a paper because you're going to want to take some notes. I can pretty much guarantee that. And share this episode with somebody that you know needs this information. And by somebody, I mean everybody. Everyone needs to hear this. So take a listen. Let me know what really resonated with you. I'd love to hear what you're taking away from it, and then share it. The more we can get this information out to the humans in the world who need it, the better it is for all of us. So please enjoy Dr. Sarah Wilson. Wondering what the F has happened to your body and your life? You're in the right place, my friend. Welcome to season 3 of Transforming 45. Where we dive into the incredible stories of how brilliant humans are navigating the midlife squeeze with courage, passion, and a healthy dose of humor. Don't miss out on any of our heart-led episodes. Hit the subscribe button, leave a 5-star review, and if you're inspired, share an episode you love with a friend. It means more to me than I can express that you're choosing to spend time here and sharing our message of midlife revolution. So let's get into it. Hello, and welcome to this week's episode of Transforming 45. This week, I'm so excited to welcome Dr. Sarah Wilson. She is the founder of Advanced Women's Health Clinics, and she is absolutely passionate about educating professionals and members of the public on a wide breadth of wellness topics. She is on a mission to help all women get healthy naturally with naturopathic medicine. She does this not only by seeing patients, but also is a mentor to naturopathic doctors across North America with her professional program, Naturopathic Clinic Mentorship. Dr. Sarah, I am so glad you are here today. We have so much to talk about. I heard you speak a couple of weeks ago at That Goods event with Dr. Mary Claire Haver, and I just was like, oh yeah, she is my people. So welcome to the show.
Thank you so much for having me. I know it's always fun when you get to reconnect with people on a podcast because we already have that basis and you can tell. So that we're just more comfortable and we just jam and go from there. So, no, I love it. And thank you for having me. Being someone who wants to deeply empower women, they only get that education and empowerment in channels like this.
Yes.
So I am always so grateful to have anyone's ears and anyone's attention and to be trusted to be featured on anyone's platform because that is the grassroots. That is how women are going to hear the information they need to hear and wake up to the fact that they are so capable of feeling like themselves. And it doesn't have to be complicated and chaotic and crazy and all of those things.
Yes, that's so important. I am going to ask you that first question, but I do want to just say, I think we get so caught up in this cycle of it has to be hard, it has to be complicated, all of those things. And then that's what becomes the barrier because we have this mindset of, no, this is going to be too hard. I'm just going to keep living in the chaos that I'm living in because that's easier than change. And so I think what you just said there is so important that it really doesn't have to be. You just need to know the skilled people to ask for help.
Yeah. And I'm sure we'll get into this as we go, but I was just at the National Women's Show too, and we talked to probably hundreds, if not more than 1,000 people. And the roots are so similar to the conversation. Yeah, I won't spin out. I won't get
Yeah.
carried away. We'll follow the path and then we'll get there.
All right, so let's roll back to the beginning. So, Sarah, tell us, who are you and how did life introduce you to this version?
Yeah, so as you guys heard, I am a naturopathic doctor. I'm a mama of two spicy Latino boys. I am a researcher. And what's most important is that I am the patient that needed the type of care that I now offer. So I was undiagnosed with celiac disease until I was 18. I was in and out of hospital. I was obese for no good reason. So I was about 100 pounds heavier than I am now. And I was healthier than I am now, to be completely honest. I did all of the things I knew to do, and I feel like I just stumbled across one health issue after another. So, fast forward, was diagnosed with celiac disease, cut gluten. In that process, saw a naturopathic doctor, decided I was going to come off birth control, didn't get a period back for 6 years. Was told when I was 21 I was never going to have kids on my own. Then was later brought my period back on my own because no one could figure out how to do that. Told I wasn't gonna have kids on my own, have two. So I speed it up for the sake of like, I don't ever want anyone to look at my story and be like, oh, wow, like it must have been so hard because I am grateful for every moment of every struggle I had because I now get to prevent thousands of women from having that struggle, right? But it is fundamental to who I am and why I'm good at my job is because every step I have taken was first to figure out myself. And then I figured that out. And then I carried that same diagnostic process, that same thought process into the life of other people. And then they got better. And then I got busy. And then there was demand for my clinical care and support. And then there was demand for more and more clinics. And now we have 9, right? Soon to be 10. But it's really come from this organic place of I was the person who was told I was the most complicated. I was the person who was told no one can figure you out. This is just your destiny. You're the exception. I heard that my whole life, and now I've decided to be exceptional for a completely different reason.
That being exceptional. It's so, yeah, that is such a great way to frame that. And it's one of the things that I really cherish about this work and building this community and this network of women because, and I don't want to be exclusionary to men, there are, and across the spectrum there are lots of people who share their gifts, but I do find that women in particular, when we find something that has changed us and we see it in each other, we
Mhm.
do the work of creating space where all of us can be better and it can be easier for who's coming behind us.
I could not agree anymore. I always say that's why I love treating women because I treat one woman, but then I inadvertently treat her whole family, her community. And so my like end game is to treat every woman in a position of power in the government. Like, not
Yes.
me personally, to be clear.
Yeah.
Like, advance women's health to be the place where women in positions of power come to feel like themselves. Because when they feel like themselves and when they get better and they take action from their highest confidence, their highest output, their highest productivity, not feeling burnt out, not feeling overwhelmed, when they take action from there, magic happens. And I am so fortunate to have a lot of patients that are running businesses, that are CEOs of large companies that have a lot of impact. And I see how they change their entire corporations or communities or lives, or the stay at home moms who change everything about their kids and how they function in the world. And that is why, like, we are launching advanced men's health at a certain point, but like, that's why it's women at my heart, at my core, is because the trickle impact is massive.
It really is. I'm excited to hear you say that because as we record, it's middle-ish of November. There's been some changes in our world that have some significant impact in lots of ways, especially those of us who are advocates in women's health. And so before I did this work, I was an educator for 20 years. And the last part of my career, I was at the board level working centrally. I watched really incredible women have to put on the armor of, there's so many words that I want to use here, but put on armor and become versions of themselves that they were not to
Mhm.
survive
Yep.
in the very patriarchal structure that exists. Like, I'll speak specifically at the top of education and how that trickles out. And it was heartbreaking to me every time because I knew what their intentions were when they went into those positions. I knew the work that they wanted to do, and then I watched them just change to survive. So doing this work is so important so that women feel supported and connected to know that they can do this work from their lived experience and perspective rather than having to change.
Yeah. And it's so I do this is like a total aside, but I think it's important. I subscribe to the theory of beliefs trauma, right? And this kind of like identity trauma, which is a conversation that happens a lot in EMDR, right? You have a belief about yourself, you have an event that proves it true, that activates your nervous system. And trauma is literally just, again, it can be like a significant physical trauma, but at the end of the day, it's an activation of your nervous system and how your body responds when that event is not there but comes back up again. And if you believe you're not good enough and you don't deserve a seat at the table, and you're constantly feeling like you're clawing and trying to change, right? If you believe that someone else's opinion is more important, more valid than yours, then that causes such a deep activation of your nervous system when you see that over and over and over again, that we have four nervous system responses, right? We have fight, flight, freeze, and fawn. And for a lot of women, fawn is really strong. It's the people pleasing. So what happens is you have those beliefs activated, right? Then you move into this people pleasing back behavior. Then that gets reinforced. Your nervous system calms down, and then you just keep doing it. And we see it happen so much, so subconsciously, that I think until we can acknowledge the belief based nervous system activation that comes from a patriarchal society, right? We're never going to be able to navigate forward because our stress response teaches us to people please in those situations. And you're so right. So many people come in and they're so well meaning, and they're just constantly activated. They're constantly overwhelmed. And whether that is, again, because of a belief or just because of workload or because of the environment and it's actually not safe or whatever that looks like, right? But they could just end up running away or people pleasing or shutting down and going into high functioning depression or whatever that looks like. And they can't execute. And like for me, why it's so important is that's fundamentally a health issue. That's physiology we can change and we can modify and we can adapt. And so I always say, like, I could never work for anyone else. I would be the worst employee on this pace of the game. My God, like I would be the worst. But it's because I see all of that, right?
Yes.
And because I know the power of not people pleasing and how far that gets you in life. You know what I mean? That like that be my immediate response. But for so many people, I want to honor if you feel like you can't understand why you spin out and why you end up in these people pleasing behaviors, just go back to like, where is my identity being triggered? Where are my beliefs being triggered? Where is that like deeper nervous system response coming up that is resulting in me showing up this way?
Yeah, absolutely. And so many things from what you said there. And I also want to acknowledge that especially in this historical time that we're in as white women, it
Mhm.
is really important that we do more listening and making space because there's a lot of aspects of our identities. I'm trying to intentionally put myself into places that make me feel uncomfortable because it means that I have learning to do in that space. And instead of being reactive, like of course, my nervous system, I feel it start to activate. And the question I ask is, what do I need to learn from this? Instead of giving into the reaction, it's the what is it? Like, is it that this is activating in me the people pleasing and needing to be seen as good, as needing to be, loved, beloved by everyone? And that may not be the case right now. And it's something that we need to be aware of and really think about our reaction to it,
Mhm.
because it's complicated times. And the more we can listen and make space for and provide love to other people, I think the better we can move through this time.
Absolutely. And you're so right. Like part of listening and being present is being able to have your feet on the floor. And this is where, as much as I love to talk about like the nervous system from an identity perspective and from a beliefs perspective, 75% of our stress response comes from blood sugar. Right?
Right.
Like a
Yeah.
huge percentage of our stress response comes from blood sugar, from nutrient deficiencies, from inflammatory responses in our body, from bacterial imbalances, right? From actually like having damage to the energy making machines within our cells. And so it can be a really empowering conversation to have to anchor the conversation we just had, that you can still take action of this huge percentage of your stress response to compensate for the times that you were completely imperfect from a being triggered perspective, right?
Yeah.
And that's where, like I said, even honestly, even years ago, first round, right? I was a lot more activated than I was this time
Mhm.
because my physiology is in a better place. I'm stronger as a person. And also, probably because I fundamentally believe that I will have a bigger influence in change in 10 years than I believed I would a few years ago. But there's so much we can control within that stress response. So if you're sitting here feeling like, oh, great conversation for you two who probably like meditate on the rock and ground and blah, blah, blah. But like, I'm just pissed and I just want to punch someone. And like, then people please around them. I always joke, my nervous system response is fight fawn. So I'll like throat punch you and then make you dinner. But if you're feeling that, like if you feel like you can't get out of that, there's probably an underlying physiological component as well.
Yeah, absolutely. And I really want to get into that, especially through the perimenopause and menopause lens, right? So,
Yes.
one of the things I always say about this time is that, yes, it is challenging, it's hard. I'm not going to negate any of those things. It is also a gift because your
Hmm.
body is demanding your attention in ways that maybe we've been able to ignore before, but now we absolutely can't. And I was wondering if you could speak to a little bit more of that blood sugar and how that impacts everything, just purely selfishly. I mean, anyone who knows me knows that I need to be fed on a regular basis, or else like when I was teaching, my colleagues would be like, have you eaten? It was always my tell, right? Like personally, I know how important that is, that my capacity is vastly different when I have the nutrition that I need than when I don't. And so what are
Hmm.
some of the things that you start to see really shift and impact women who are in that perimenopausal, menopause, and then postmenopause phase?
Yeah. Oh my gosh. You just opened a diagnostic door and I want to walk through it. But
Do
I
it.
know, right? We'll do this thing. So I have started clinically, especially in the last 5 years, because things have changed, to separate different categories. So I'm going to kind of break them down and just explain a little bit how I perceive what's going on in those different categories, and then we'll get into it. 37 to like 42, right? 45 in some situations. I call that like peri chaos. So you're not fully perimenopausal yet. You're not necessarily going to see changes in your blood work that would tell you you're perimenopausal, but things are shifting. The C's have shifted. Then there's like the 42 to 52, which is perimenopause. And then there is postmenopause, which is you're in menopause technically, and I'm sure you covered this 1,000 times, a year after you've not had a period. Um, Almost every patient I have, this is what I lovingly call the comeback tour, which is like 11 months and 28 days, and you're like, I'm menopausal, and then you bleed, and you're like, another year? Like, are you joking? Like, what cruel trick is this? But there's that window. And they're all defined by shifts in different states. In that 37 to 42, In that situation, what we see as some of the biggest drivers are things that decrease your hormones of resilience, right? It's a decrease in resilience. So what we're seeing is hormones like DHEA and testosterone are dropping. Very DHEA. If I had to have like a favorite sex hormone, it would be that one. It's so stabilizing to the immune system. It is so stabilizing to the nervous system. We have research to show that the ratio between cortisol and DHEA can directly impact your metabolic function, your muscle
Mm.
mass development, your bone health, like very, very critical marker. So we see really big shifts in one, insulin, and liver function is another one at that age category. And then we see changes and decreases in these androgenic hormones. For anyone who's watching the video, if anyone is, picture like a graph, right? An XY graph. So what's happening is your hormones are fluctuating across the bottom. And the bigger the gap between the bottom and the top, right? The bigger the gap around that line, the bigger the fluctuation around that line, the more the symptoms are. So that line is your androgens. In my mind, this is how I describe it to people. And so if your androgens bottom out, then you're inevitably going to have bigger and bigger fluctuations in terms of felt symptoms. So that, again, 37 to 42, there's just metabolic responses going on in a very big way. There's inflammatory responses that are kicking off, and then there's lower DHEA and testosterone oftentimes. Then we get into the window of perimenopause, which is defined by inconsistent and irregular periods and massive fluctuations in estradiol. So there's often high levels of estradiol and lower levels of progesterone. Then when we get into menopause, that's where we see low. Everything's low, 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 low. So why that's important is because if you start at the age of 37 with metabolic dysfunction, and then, right, you have a lower level of hormones that are supporting muscle mass and resilience and cortisol, then we can see that compound into causing more and more blood sugar issues and more what we call insulin resistance, which I'll get into in a minute. Then we decrease progesterone, which is our anti inflammatory, neurologically supportive hormone, and we increase progesterone or estrogen, sorry, which is pro inflammatory and which has a massive impact on satiety on the brain. Then you see massive fluctuations in inflammatory responses and you see massive fluctuations in satiety. And therefore, we see insulin change and food change. So there is a fair amount of research that is suggesting that you can't sample someone's blood for any hormone and it'll tell you, even if you're doing multiple samples throughout the day, it won't tell you how much hot flashes someone is going to have. But if you sample someone's insulin, it can. There's a straight line. The worse the insulin resistance, the worse the perimenopausal symptom.
Fascinating.
So it's so fascinating. So if you have any questions, I can pause, but I want to bring it back clinically to how that's going to show up for people, like signs that they could be experiencing it.
Yeah, let's do that.
Okay.
Yeah.
So just to back it up, I heard probably 100 times this weekend, I don't have insulin resistance. My glucose is fine. That means nothing. Okay. So when you go to your doctor, they do not test your insulin 99.9% of times. They test your glucose. 75% of the population has insulin resistance. 75.
Wow.
It's just insulin resistance is a spectrum. And the first two or three types of insulin resistance, you don't see changes in your glucose. So your glucose doesn't rise. No one's told you you're pre-diabetic, but you're starting to feel tired. You're starting to feel hangry. Some people have hair growth on their face, right? Or anywhere that you would typically think like androgenic hair growth. Some people have hair fall. Some people have skin tags. Some people have a change in pigmentation around their neck, underarms. Some people have weight loss resistance. They're doing all the right things and they can't lose weight. Some people have melasma. That's a combination of estrogen and insulin. Some people have fibroids. That's a combination of estrogen and insulin. They're growth hormones. So we see these things show up, brain fog, again, like needing food to sustain. So, why does this happen? Well, insulin is a hormone of storage. So it stores glucose into your muscle and your fat cells. It stores amino acids, which is what we break protein into your muscles. Okay. So it's storing, it's a one way path. It is not saying come back out. So, in the first few phases of insulin resistance, what happens is someone's insulin, so their storage hormone, is going too high with meals and staying too high too long. So then their blood sugar drops 2, 3 hours after they eat a meal, but their hormones, which is the signal to tell you what to do, are still saying store away, store away, store away. So that means you are not pulling fat out of your fat cells and you're not what we call metabolically flexible. You can't use your meal and then use your fat, use your meal and then use your fat. So
Okay.
you end up having to eat constantly to regulate your blood sugar. I have the ultimate quotes around this. No one should have to regulate their blood sugar. Their blood sugar should do it on their own. But we have to do that because we do not have the ability to easily transition into using fat, using stored glucose without having this massive stress response. And then we make it worse and worse by consistently snacking.
Right. So many things are in my brain right now. So again, just like thinking through my own experience with this. So I'm not a snacker. I eat like breakfast, lunch, dinner. It's never been something that's been part of my routine, let's say, or been pulled to crave that. But I definitely have those lows to the point where like I will be visibly shaking. Like people will say to me, "You are quivering. Do you know that?" And I'm like, "Yeah, I know. I just need to eat something." So
Mhm.
metabolically, what's happening in that moment?
Is it how far can we go? Like, how close can we get to your personal health? How much do people on this podcast know about
They
you?
know everything. I'm an open book. Just go for it.
You can see everyone laughs when I get like my doctor hat on, right? Because I like my whole body shifts and they're like, oh, she's going for it. So, is there a type of meal that you eat before that happens?
I'm pretty well balanced. Like I try to always have like a decent amount of protein, a decent amount of vegetable. One of the things I'm noticing going into perimenopause, however, is that I probably am not getting enough carbohydrate or the right type of carbohydrate because
Probably the
that
latter more than the former. Yes.
yes, yeah. So because that is when I definitely notice of not being able to feel full, of having more shakes and more quivers.
Okay. So, it's interesting, right? When we look, so there's something called the food insulin demand. So most people are very used to what we call the glycemic index, meaning you look at how much glucose, your blood sugar, rises when you eat a food. But glucose is the outcome of insulin, right?
Right.
So
Okay.
we actually need to know how much insulin is raised to deal with the food. And if you know how much insulin is raised, you can predict an outcome. So the food insulin demand is what my clinic uses in order to customize people's dietary approaches. So if you are eating a high insulin demand food, meaning you're eating a food that puts you into a state of storage, but you have not consumed enough nutrients or sugar, then what happens is your body's still going to store because the insulin's still there, but your glucose can drop down and you can feel hypoglycemic or feel low blood sugar. So, examples of that we don't typically think of: whey protein, BCAAs, or pre workouts, they're going to increase storage. This is why so many of my patients literally just stop pre workouts and then they lose weight and they're like, what is happening here? We know that red meat can do that. Any protein is very insulin stimulating. So, if you have an inappropriate insulin response to protein, then that can result. This whole like cottage cheese phase that we're going through, like dairy and dairy protein in general. So, we talked about whey and things, but they're very, very insulin stimulating. So, they can cause a low blood sugar response on the other side. So, it can be those foods, it can also be bananas, tropical
Mm,
fruits, sweet potatoes, right? Like a lot of these foods that we think are reasonably healthy have a massive insulin load on them. And so oftentimes people are like, oh, I eat rice, or I would never eat rice, but I'll eat sweet potato. And I'm like, they actually are pretty much the same from an insulin perspective. So sometimes it's the combination of those foods as well that are contributing.
Okay. So what do we do? So when I was watching you a couple of weeks ago, you were talking about that blood test, right? That's looking at yes. So let's get into that a little bit because we talk a lot, like in the perimenopause world, around like a blood test does not diagnose perimenopause, menopause. And in the blood test you were talking about was a lot of information that you can learn about what's happening in your body in the blood test that you were talking about. So let's get into that a little bit.
Yes. So to comment, when we're talking about perimenopause, we're talking about how the brain talks to the ovaries and then how the ovaries respond. And the ovaries response is extremely inconsistent. So if you are in menopause, then you're going to see that your brain is screaming at your ovaries. You're going to have a high, what we call LH and FSH. But until you get there, it's very inconsistent. But what we can do is look at the core other components. So, one of the tests I do that you were talking about is called an insulin and glucose challenge test. So, it tests your insulin and your glucose fasting, and then insulin and glucose at half an hour, 1 hour, and 2 hours later. So, based on that, we can see how your body tolerates carbohydrates. If you if you have high insulin fasting, you're not getting into a fasted state. Your body still thinks it's fed. In that situation, that's where you might actually do better doing something like intermittent fasting. If someone has a normal fasting insulin, then there's no reason they can't eat when they wake up because their body is in a fasted state, and that's fantastic. And then the key is, though, you have to look at what happens. So almost all of the newer research coming out showing the cardiovascular impacts, cardiovascular risk, things like that, and even mental emotional symptoms and risks are coming back to this conversation around the peak insulin and the peak glucose. So if you are completely normal and then you have glucose and your blood sugar shoots way too high, right? Like in Canadian units, if it's over 7, so if you're 8, 9, 10, 11, and your insulin is very high, then that's telling us that was way too much. Your body could not handle that load. And then we watch how it drops because in some people, their body can't handle the glucose load, so their insulin keeps going up. So then they store fat the entire 2, 4, 6 hour period. In some people, they overshoot how much insulin they need. They make more than they need, they store away more than they need, and then boom, they plummet. And their glucose gets extremely low and everything drops eventually, but they just feel atrocious in the process. So that is another situation. So the test is so helpful as a doctor because I can then say, oh, this is how many grams of carbohydrates you're probably going to want to eat at breakfast, lunch, and dinner.
Right.
This is how much you can tolerate. This is telling me that you should fast or not fast. This is telling me you should eat 2 meals a day or 3 meals a day or whatever that looks like, or 5 meals a day, right? Whatever that looks like, it'll tell me that. And to me, that is one of the most empowering pieces of information that you can give to someone who has spent the majority of their life trying to understand their body to the point that a lot of my patients are completely dissociated from their bodies, right? Like
Mhm.
they're just, I don't know how to manage this. I am doing what I did 5 years ago. It's not working. My body's working against me. I'm broken. Like all of these conversations come up. And it's devastating to me because this is a cheap friggin' test. You know what I mean? Like I always hesitate to say the cost because Life Labs puts up the cost all the time, but like it's a less than $50 test. It is so inexpensive for someone to be denied access to it or not know it exists when it could be the thing that changes their perimenopausal experience. It changes their experience of their bodies. Like I lost weight when I understood insulin and I eat more and I eat, you know what I mean? I have more flexibility and all of those things than I ever did before because I know what levers to pull. And that's what I want for everyone.
Yeah. Absolutely. And going back to like right at the beginning of the conversation, when you said, we're so disassociated from our bodies because we just don't know what to do, that is often the heart of the conversation when women come into my space of like, I don't even know. I don't know myself. I don't know my body. I don't know how they're interacting. And I do this activity when I'm facilitating groups where I have people write down everything that's happening on the inside. Like what's all your physical experience, what's happening? And then what's happening on the outside? So what's the life context that's happening? And then let's look at how those things are intersecting. What I'm coming to observe over some time is that people are really comfortable with writing down all the physical things that are happening, but are really reluctant, and it makes them emotional to talk about the context of what is happening around them. And so I'd love for you to speak to that a little bit about how our life context absolutely intersects with our internal experience.
Yeah. And what are some of the examples of context things that you pull out? I would love to comment in a specific.
Yeah. The context can be everything from like race, marital status, kids
Mm.
or not. Where are you at in your career? What's happening? What's your stress level? Are you caring for elderly parents? Are you caring for children and elderly parents? Are you disassociated from your body? Are you feeling hopeless and disconnected? Do you have community? Are you connected? Like all of
Yeah.
those things.
Yeah. Yeah. No, okay, that's perfect. That's exactly what I was thinking. So it's our body is the physical manifestation of everything coming at us at all times. So I'll use this example because I think it's an extreme one in a lot of ways, but it's really powerful. So I have a condition called endometriosis. It is an inflammatory condition that's affected by hormones where I get cysts on my ovaries and can get a lot of pain with ovulation and my period, et cetera, to the point that I've passed out historically. Well, for my life, like, to be completely honest, aside from a few periods of time, I was able to take enough Advil to navigate forward and I was able to move forward. And then with so after the birth of my first, all kinds of stuff happened there. But I had a physical injury to my SI joint. And then we had a home invasion. And so after that period of time, I developed chronic pain. I couldn't lift up my kid. I was in chronic debilitating pain to the point that I would be like on my back for a week at a time, like severe pain, the worst I've had. And I was told forever, nope, it couldn't be endo. Nope, 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 nope. I had to reassociate to my body and deal with the response and the nervous system components and the lack of nutrition I had from carrying a child, the how overscheduled I was at that time, how much I put on myself. I had to deal with all of those components in addition to take the supplements, change my diet, do the things to get out of that place. But the context was the last drop in the physical bucket. It was the last thing my body could handle that then tipped everything over the top. And it's so we have to look at all of those things together, because if I had just went to therapy, and I say just, right, and addressed the nervous system responses that came up, the like actual lack of safety we had, all of those things, I would have gotten 25% of the way there. But because I addressed all of the physiological issues and the psychological challenges at the same time, one, I could get a result quicker, but two, I could allow those things to have a similar story that would then allow them to integrate with my body. I think the dissociation piece comes when you feel really out of control and you feel like you're separate from. And in the face of chronic pain, in the face of, I see this all the time in perimenopause, like your body's changing and you don't want to, and you're really struggling with that connection. I have found the faster we bring those things together, the faster the results you get, right? You can't do one without the other. It's about reconnecting those things, but also allowing those stories to overlap, right? If I just went on and was like, oh, well, yeah, like everything flared from this home invasion and my massive stress response, but I took this supplement and did this acupuncture and blah, 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 and I felt better. If I had just done that, the healing wouldn't have happened. You take 25% from the somatic and like the therapy piece, you take 25% from the supplements, and together it equals 100%. It doesn't equal 50%. And that's the thing I try so hard to integrate into people's treatments, to the point that like literally, I didn't end up writing the certification because welcome to my brain, but like I'm a hypnotherapist,
Right.
right?
Yeah.
Like I believe so strongly in the connection between those forces, between the psychology and the motivation and the beliefs and the nervous system, that I think that's part of why my patients get such good results, is because I'm capitalizing on both at the same time, right? As opposed to trying to treat the without looking at the elephant in the room.
Absolutely. And I wanted to be really clear about that before we move into the menopause hormone therapy conversation, because one of the things I worry about in the menopause, perimenopause space is that people become fixated on the hormones as being the fix, and that well, just take these, I'll take these pills or I'll have this patch and everything will be fine. And it is exactly what you were just saying. It is a part, like dealing with the physical symptoms is part of the healing story, but it is not the fulsome healing story. And so, with that in mind, in particular, as we go into this conversation, I want to start with testosterone, because I think we've talked about like estradiol and progesterone a lot on this show. Not that it doesn't mean this is an important part of the conversation, but the question I've been getting a lot lately is what's up with testosterone? And I wasn't familiar with DHEA. So if you can sort of like talk about that a little bit, and then we'll get into the testosterone conversation, that would be fantastic.
Yes. So DHEA is a supplement in a lot of other countries, and it's a drug in Canada. So this is facts. DHEA, most of the research is in fertility, in supporting metabolic health, in supporting muscle mass, things like that. That's where a lot of the research is. But DHEA is kind of our mother hormone. So DHEA can become testosterone, which can then become estradiol. So there's this pathway. And DHEA is an adrenal hormone. So it's not actually made in your ovaries, it's made in your adrenal glands. But because whoever is up there can be a little bit of an a-hole sometimes, they both drop on the same sequence. And what we're seeing now is that women are experiencing this drop in DHEA far before they see a drop in their ovarian hormones, which is causing a whole cluster of issues. So DHEA is a balancing hormone of resilience. We know it improves antioxidant load. We know it improves fertility. We know it improves all of those pieces, but we also know it can have a hugely positive impact on mental health, on bone health, muscle health, all those types of things, because your body can kind of choose what to do with it, which is always, I always love going as far upstream as I possibly can. Right? Like, let's give the body the choice to know what it needs to do on its own, as opposed to me trying to make that choice for it. So DHEA gives you that option. DHEA has a lot of research on vaginal use as well, with prolapse, with vaginal concerns. It's early days, but there are a lot more studies coming out on those who have hormone sensitive cancer and DHEA as well. So that's a newer conversation. So I personally think DHEA is one of the most underutilized hormones in perimenopause because of how stabilizing it can be to the whole system. It's challenging in that not all providers, so I can't prescribe DHEA. We have a nurse practitioner that can prescribe DHEA. Um, but it's not easy to access. It's similar to testosterone. It's not always the easiest to access thing. So that's DHEA in a nutshell.
Okay. All right. So, what's up with testosterone? Why is this becoming a bigger part of the menopause conversation? What's happening there?
But there's a lot of mixed opinions about why it's becoming a huge part of the conversation. So I'm going to start this conversation with whatever works for you. And if you feel great, that's phenomenal.
Yes.
There are a lot of people using testosterone to medicate women in perimenopause and menopause to have the sex drive of a 16-year-old. I don't think that's, I don't want to see the word appropriate, because like, you do you. You know what I mean? You do
Yes.
you. But I don't have sex every day. I don't personally want to. I don't have time to. I have a 2-year-old and a 5-year-old, right? So I personally don't have a partner that has an expectation. He probably would like to. He's probably going to listen to this and be like, Sarah, don't you dare talk about our sex life, right? But there is something to be acknowledged about youth and the porn culture and this societally like applied expectation about how much someone should have sex and how often and what that looks like. So the reason there's a lot of controversy is because testosterone is being used in excess in a lot of parts in the world to try to have someone have what we call super physiological, so way above what is normal to level of testosterone to contribute to more sex drive. Again, if you want to do that, rock on with your bad self, but that's where the controversy comes from. Testosterone, just like any other hormone, is a very valuable part of a woman's physiology. It helps with muscle mass. It helps with the integrity of joints and tissue. It can become estradiol. So it's a buffer hormone. It can help with libido. This is something we don't talk about at all. But so if you look at the vaginal canal, there are a concentration of androgen receptors in different places than estradiol receptors. So if someone's experiencing pain with intercourse, if they're experiencing dryness, if they're experiencing like any physical sexual symptom associated with their vagina, then in that, to maximize the benefits, you really do want androgens and estrogen. It's just a very normal balance to have. So when used in normal physiological concentrations, you have a ton of benefits to cognitive health, again, to like muscular health, metabolic health, all those types of things. You just get more receptor access, which is more efficacious. It's part of the controversy comes from similar to men, right? Like the abuse of a hormone and giving super high doses to create a state that we just aren't naturally meant to be in.
Thank you for breaking that down so clearly. I hadn't made that connection to youth and porn culture, and so I think that's really fascinating, and we could probably do an entire other episode on that alone.
It's important to talk about because as a practicing clinician, I have these conversations. I get asked things all the time. And to me, like it's funny, even coming on podcasts and stuff, people are like, you talked about what? I'm like, I talk about this all day. Like this is my norm. This is the conversations we need to have. Like even we have a podcast that we launched recently and we have after hours episodes, which is literally like a whole bunch of NDs sitting around drinking wine, talking about shit that no one else wants to talk about. Like
Amazing.
it's a huge part of what we want to do and like the message we want to spread. But it's these types of conversations that people are coming to me with. And like I had a patient the other day and she was like, what's normal for like the number of times that a 60-year-old man wants to have sex? I was like, I don't know. You know what I mean? Like there's no standard normal. What works for you? What works for your relationship? What you know what I mean? Like what is important to you in this situation? And so we were able to have that conversation. But I think there's a lot of nuance to it, and it's just important to acknowledge where it is in the room, I guess.
Yeah, absolutely. And the nuance is so important. And what you were saying is it's really about for the first time maybe in your ever in your ever loving life, centering yourself and deciding like what do I want? What does work for me? What does feel good? What don't I want? Right? Because sometimes, people will say to me, "Well, I don't know if I want all of the things that come with hormone therapy." I was like, "Well, then don't do it. It's it's totally your choice. You get to decide, and this is your time to make those decisions."
I want to speak to HRT in general in situations. So I've been accused of being an estrogen pusher in the past, and here's why. Because if you have a hysterectomy at 41, your chances of osteoporosis and cardiovascular disease are so exponentially high that there is a huge difference between replacement of a hormone after menopause and replacement of a hormone during surgical menopause. And that conversation is not being had right now. We also, and this is not something that I will get into, but we have, I personally think, probably about 5 times more premature ovarian insufficiency in the last 5 years than we have ever had in the past, ever. Like the number of 20 somethings I have that are in clinical menopause when they come into my practice is exponentially higher than I have ever seen. And so, because that conversation's happening and no one's talking about it, because hysterectomies are happening and the rates are not being publicized, we're mixing two things together. If you go through menopause before, technically before the age of 45, you have premature menopause. Okay. You can lose 2% bone per year. If you lose an extra 10%, 20% bone compared to someone else who went through menopause at 52, that is a significant change. So I will happily be a hormone pusher if you have gone through surgical menopause or you have had premature ovarian insufficiency, because the research in terms of cognitive decline, the research in terms of bone health, cardiovascular health are very, very high. But because there is such a fear still of hormones, even people in that age category are not accessing it. And so, what you want to do with your body is always your choice. Fundamentally, end of day, as long as you have the proper education, you make the choice that feels right for you. Wham, bam, fantastic. Love that for you. Let's do it. But there is so much fear around what actual education looks like that I think there's a lot of resistance to it still. And so, like, I literally train medical doctors on the latest research on HRT. Like, I am very confident in the pros, cons, weighing all those things out. But we need to be able to understand where you are on that spectrum and what your risks are without the hormones based on when this is happening for you, because you're going to have listeners that came on here because of a hysterectomy they had at 41 or because they're having symptoms at 40. That's a very different conversation than someone who goes through at the average age of 52. Whatever you want to do, we will work with and we will support, and it is your body and your choice fundamentally. But I had a number of those conversations over the weekend where people are 10 years post-surgical hysterectomy, they're 48 and they're suffering. And they're like, no one told me.
Thank you so much for being so really clear and direct about that, because you are 100% right that that information is not getting out, right? I think sometimes when we're in the menopause space, we think that everybody knows and is just saturated in information the way that we are. And then you're
Me
like, this,
every single day. I'm like, no one cares. And then I'll say something and everyone's like, this is the most novel thing I've ever heard in my whole life. And I'm like,
right?
okay.
I know. You just take like one little step outside of our little bubble, and you realize that there is essential information that women are not getting that will improve their quality of health span, that is so important. Like I'm sure I've told this story before, but like I look at my grandmother who is 93 years old, and I was the first person, like when I was doing my menopause coaching training, I asked her about her experience because my mom passed away at 52. So I didn't have that generation to ask. And when I asked her about her experience, she's like, "You are the first person who has ever asked me anything about that time." And I look at her now, and I mean, she's 93, she's spicy AF, and she is living life. And her mobility is not great. She is frail. She has like she's got increased chances of fracture, frailty, and falls. All of the things. She walks with a walker. And I just think if she had known, because she was one of those women that the WHI report impacted, she was on hormone replacement. That report came out. I still remember my mom like bursting into her house. She was like, "You need to get off of that right now." And then she also didn't know, so she immediately went off and also didn't know about the impacts of weight bearing exercise, about nutrition, about, about all of the other pieces that are so important. And I look at her now, this woman with this incredible mind and a body that is weaker than her brain.
Yeah. And it's such an important conversation to have. There's still so much fear around it. There is still so much misinformation. I hear multiple times a week. Well, if we were meant to have it, we would still have it. I'm like, okay. You know what I mean? And again, different strokes for different folks. You
Mm-hmm.
have to do what feels right to you. But I think this is also where I was talking to someone about this the other day. I'm an entrepreneur. I don't know what the hell I'm doing, but I have never, ever accepted someone telling me what to do was the right piece, right? Like we were talking about before, like I would be the worst employee to handle, right? Curiosity is one of our clinic's core values. It's one of my core values as a human. And so I think there's a component of the ones who have that tendency to be spicy, to be loud, to question the norms, to question everything they're told is true, to stay curious. We have to be on the front end of it because there are so many people that don't have those values that have had curiosity literally beaten out of them. Like, and you look, right? Like our generation, I was very lucky to have parents who encouraged my curiosity. I can't say the same about a lot of other parents. They're like, just because I said so, just stop, just stop. Just you don't need to ask, right? And I think there are a lot of people who take that on, a lot of women who take that on about their health, right? Like, I can't keep asking questions. I shouldn't keep asking questions. You know what I mean? Like, even though their gut instinct is there's something there, they were told by an authority one time that this is how it should be. And they didn't question it. And that's showing up in the menopause literature to some degree, for sure, but also in menopausal care. Because if they've been taught to not ask questions their whole life and then they get into this phase, are they allowed to? Are they not? You know what I mean? How do you get clarity? It's I don't have an answer to the question because obviously not everyone can see me or someone on my team or you, right? But it's it's really, really important that we're looking at it.
Yeah, absolutely. And so for listeners, like one thing, I mean, there's 1,000 things to take away from this conversation. And in terms of action going forward, so one, we'll have all of your contact information in the show notes so that people know where to find your care. And if there is one question or one statement that someone could write down before going into seeing a healthcare practitioner, knowing that every woman's story is different and everybody's treatment will be different, but what is one place someone could start if they are feeling that intimidation factor?
Such a good question. So part of it is find a practitioner that doesn't give you that feeling. That's a big one, right? I had people, my team, so we were at the women's show all weekend. My team had people asking questions that they've never asked a provider just because it felt approachable. So that's one thing. The number of people we had who were like, I didn't know care like this existed in Canada. You know what I mean? Like I was literally getting ready to go to Europe or to go somewhere else to get this kind of investigation. So part of it is just being mindful and aware. The other part of it is calmly looking your provider in the eye and saying, I don't feel like myself, and it has nothing to do with my mood. And we know that the use of antidepressants and anti-anxiety medication goes through the roof. In 2025, my team is going to be having a large educational conversation on the difference between perimenopause, perichaos, and ADHD. Not to take
Yes.
away from the diagnosis of ADHD, but there are parallels that mean that you could go on Vyvanse or Concerta or Ritalin and feel absolutely horrific, which we see a ton. So those medications are used in excess in this patient population. So this is where we need to acknowledge the conversation around like, I do not feel like myself, and that has to be enough. And if that is met with any sort of resistance or drive to overprescribe, one, know you have options. And two, you have every right to say, that doesn't feel right to me. Is this a limitation in your knowledge about this subject? Right. Or, and meaning I should see someone else, or do you feel like I'm at the end of my rope here? And I should, you know what I mean? Like you can
Yes.
ask questions like that, right? And people, I have patients that I'm very fortunate, right? There's not a ton of them, but I have patients that come in and they don't get well. And so they'll say to me, do you feel like you could go to a mentor? Like, do you feel like you don't know? And I'm like, here's the gap I have. This little piece here, I can't make sense of. I can't add up. Try this person. And then if that works, everything's going to click into place. Come back here and then I'll be able to put the puzzle back together, right? Or I have conversations with people. This is because your nervous system is so dysregulated and it is not your fault and you are not crazy, but we need to build in some somatic work, some EMDR. We need to build in some herbs to regulate your nervous system, and then we'll get you there. But I think it's a really powerful question to know you're safe to ask is, okay, that doesn't feel right to me. Is there another option? And if your care provider looks at you and says no, then don't, when someone tells you who they are, believe them.
Yes.
The most grieving happens from when you keep going back to the same person asking the same question when they've been extremely clear to tell you they're not going to be the person who has the answers. And sometimes they can't say that from an egoic place or whatever place. That's fine. That's fine. That's not a problem. But when they tell you who they are, believe them. And if they tell you they can help you, believe them. And if they tell you that that's just how you're going to feel or it's just depression or whatever, even now, like the research on anxiety and depression is showing that insulin resistance and inflammation are massive drivers of those conditions. It's not a deficiency of serotonin, it's the signaling of serotonin. These are different things. So I am hard pressed. My team actually keeps joking. They want to do an interview where they just like fire questions at me and like I ninja my way through their research to be like, nope, 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 nope. But it's you'd be hard pressed to find a situation in which I couldn't find a path for someone that's different than where they're at now. And I think my team is the same. Obviously, I've trained them all for years. It's That's the sign of a progressive medical experience. And I think that's what everyone deserves to have. So, moral of the story is it's you not feeling like yourself is enough to get support, medical support. And if someone doesn't believe that to be true because they don't have a tool that can help with that, that's okay. But then you need to acknowledge that that's the end of the rope there. And you can go back for acute care and you can go back for other things, and they can be phenomenal doctors and phenomenal people. And they're just not the right person in that moment, in that phase of life for you. And we can't just sit there and keep grieving it. We have to move forward and get other advice and support and opinions. That was a long answer.
It was a really great answer, however. One, I hope you will come back in 2025 because I desperately want to have the conversation about perimenopause and anxiety and ADHD.
Yeah.
It's been a thing that's been floating around in my ether a lot. So I would love to have you come
Yes.
back and have some conversations around that. And the other thing I wanted to leave people with is that navigating the healthcare system can feel scary and overwhelming. And so
Mhm.
reach out. Like that literally is why we exist, is to help you do that. So what is the easiest way for people to get connected with you and your clinics?
Yeah, so I own Advanced Women's Health, and so we're Advanced Women's Health everywhere. Advanced Women's Health podcast, Advanced Women's Health clinics on Instagram. I am Dr. Sarah underscore ND on Instagram, but we do health strategy calls all the time where we jump on a call for 15 minutes with someone and we're like, can we help you or can we not? And if we can, what's the path that would look like? I'm like in DMs voice messaging people sometimes, and I'm like, you should see this doctor on our team. They can do this and this and this. So I think a big piece of it is, like you said, it's reaching out, it's getting support, and it's not being afraid. We have people all the time that hesitate to reach out to book a strategy call because they're like, well, what if it doesn't feel right? And then I would feel so bad not booking. And it's like, no, like this is your health. This is your journey. If we're not the right fit for you, you'll have an aha moment. You'll have a realization of why, which will make your next medical experience better. So it can be overwhelming. but just know that it's so worth it to push out of your comfort zone.
Absolutely. Thank you, Dr. Sarah, for all of the wisdom that you shared today. I have no doubt that this episode will be life-changing for people who are listening. So thank you so much for being here, and let's talk again.
Thank you so much. Yes, definitely. My research assistant and I are deep in ADHD research. So we'll have a lot to say in 2025.
Amazing. Can't wait. Thank you for being part of the Transforming 45 community. Your support means the world to us. Stay tuned for more juicy episodes, and remember to keep showing up to your life with the love and magic you deserve. Until next time.